Okay, I'm here today with Professor David Livermore. He's Professor of Medical Microbiology at the University of East Anglia. David gained his BSc in 1978, his PhD in 1983. He worked at the London Hospital Medical College from 1980 until 1997, at which point he joined the Health Protection Agency, which is now Public Health England, becoming director of its antibiotic resistance monitoring and reference laboratory in 1998. In October 2011, he became Professor of Medical Microbiology at the University of East Anglia. Professor Livermore has broad interests on the evolution and dissemination of antibiotic resistance and its relationship to antibiotic prescribing. He sits on the British Society for Antimicrobial Chemotherapy working parties on resistance surveillance, multi-resistant pathogens and susceptibility testing, and its Antibiotic Action Advisory Board, also on the Society for General Microbiology Working Group on Sexually Transmitted Infections. He's also a member of the UK government's Antimicrobial Resistance and Healthcare Associated Infections Advisory Committee and has contributed extensively to the Chief Medical Officer for England's annual report for 2011. He publishes and speaks widely on resistance and has edited several journals, including the Journal of Antimicrobial Chemotherapy and Journal of Medical Microbiology and the International Journal of Antimicrobial Agents. So, with that being said, thank you very much for joining me today.
My pleasure.
Thank you. So the first thing, I always begin all these interviews by just asking people a little bit about their background. So can you tell me how you became interested and involved in your field?
I was always, if you go right back to my school days, I was interested in natural history. I was interested in biology. I always thought I would do something in the way of a biological science at university. I half intended to study botany until I realised there were scant jobs in botany, and I attended a couple of lectures on microbiology, and I thought this is awfully interesting. And there were jobs in industry as well as in academia for microbiology. So I decided to study microbiology. I went to Heriot-Watt University in Edinburgh, got a degree there. I then spent the two most boring years of my life working for the Wellcome Trust, developing preservative systems for cough mixtures, after which I moved to the London Hospital Medical College. And you've given a history of my career from then, or at least my working career. I should say that many of those associations you've outlined are now historic. I'm substantially retired. I'm still doing bits and pieces in the way of consulting. I still have an honorary position with the University of East Anglia. I'm still doing a lot of writing up of work that we did for the British Society of Antimicrobial Chemotherapy, and occasional invited lectures. I'm out to India later in the year, and then to the International Symposium Antimicrobial Agents and Resistance in Hong Kong next year. So I'm semi-retired, but still somewhat active in the field.
Yes. And you obviously managed a laboratory for many years.
Mm.
Could you could be a very difficult question to answer. When I was writing this question, I was thinking, is it even possible to answer this question? But could you explain what your work would entail, what an average day would look like, if there is such a thing as an average day?
Yeah, I mean, I've done different things. I've worked in academic laboratories at what was the London Hospital Medical College. It's now part of Queen Mary University of London, and then at the University of East Anglia. That was fundamentally research, supervision of PhD students, committee work, seeking to publish, seeking to get grants in to do novel work. The most relevant period, I think, to what we were talking of today is my time when I was full-time with what started as the Public Health Laboratory Service, as you say, became Health Protection Agency, Public Health England, and now it's the UK Health Security Agency. It gets its name changed every so often as the government reorganises it. And there, for 14 years, I had charge of the antibiotic resistance reference laboratory. That meant that any hospital up and down the country that saw bacteria that they thought were unusually resistant to antibiotics could send them to us for a second opinion. So we would retest them, confirm or refute the resistance. We would provide them with treatment advice if the bug was very resistant. We would try to understand what biochemically and genetically the mechanism of resistance was. And if we were seeing the same new emerging type of resistance at multiple sites across the country, and this happened perhaps half a dozen times in my career, then clearly we would seek to take public health action. We would warn people about it. We would try to advise on infection control. And through all this, I should say, I worked in close cooperation with the adjacent laboratory, which was the laboratory of hospital infection. Their interest was outbreaks. So the way it enmeshed was this, that we would see, I don't know, that they would see a group of 5 multi-resistant pseudomonas aeruginosa in one hospital unit. So first question, is this 5 patients who've got the same bug through cross-infection, or is it 5 different resistant bugs? So they would type them, do a DNA fingerprint is now the normal method to type bacteria. We would test the antibiotic resistance. We would look at the mechanisms of resistance. Could the bacteria destroy the antibiotic? Was it the antibiotic couldn't get into the bacteria, or the biochemical target for the antibiotic was changed in some way? So I did a lot of work together with hospital infection folks over that period, and saw plenty of cases where unpleasant bacteria managed to spread among patients. Sometimes they were carried by, we believed, by the fingers of staff within a unit. Sometimes with a bug called Acinetobacter, they're great at colonizing dry surfaces within the unit, bed rails and such. And then with Pseudomonas aeruginosa, it's a troublesome organism for colonizing hospital water systems.
Yes.
And I'm sure we'll come back to this.
I'm sure we will. So you've been quite outspoken in writing about the Lucy Letby case. How was it that you initially became interested in it or concerned about it?
I follow the news generally, often more the political news than the sort of social human interest stories. But I'd keep seeing newspaper articles about Lucy Letby's case. And I think the first thing that alerted me to something seriously being awry was when the newspaper splashed Lucy Letby confession note. And I looked at this bit of green paper, read it, and you couldn't read this from left to right in the way of a normal letter, note, confession, or anything else. It was random jottings and scribblings and contradictory statements and overwritten diagonally. This isn't a confession note, whatever it is. It's ramblings. It's of somebody who's probably extremely stressed. And this was practically at the time of, I think it was August 23, when her convictions came through, or the first series of convictions came through. And having really been prompted by this note, I looked in more detail. I registered very quickly that all these convictions were predicated on circumstantial evidence. Nobody had seen this woman actually commit any crime. Nobody had seen her inject an infant with air or do anything else that might harm an infant. And I then learnt that where she'd been convicted of 7 murders at that stage within the unit, there'd been at least double that number of deaths in total. And Dewi Evans, I saw one day on Talk TV, which I tended to watch a bit at the time, being interviewed and saying, well, he distinguished these infants who were killed by Lucy Letby was against these others who died, and I quote, of the things young small infants normally die of congenital issues, of infection, of hemorrhage. And he drew an extremely clear distinction between these. But when I started to look at the dates of these deaths, then there was essentially a single hump of deaths. How could he distinguish so clearly? And how would the coroner and the pathologists who had examined these cases previously not managed to identify any malicious activity? So I ruminated a while on this and started to dig away on the internet, and then realized that statisticians were criticizing this case from a totally different standpoint to where I'd begun. I was coming to the view, look, there's a pile of deaths here. This looks awfully like the types of outbreaks of infection that I've seen in the past in various units, a particularly bad instance, but yes, an excess of deaths in a unit is so often infection. And then I realized there's a totally different line of criticism from statisticians. And as a scientist, this always grips me, where something doesn't make sense to you from one standpoint, and then you realize that somebody else from a totally different standpoint is also saying that it doesn't make sense. So that reinforced my strength of opinion. The next thing that happened is that I do a certain amount of writing for Toby Young's Daily Skeptic anyway, and have done since the pandemic, because I was strongly skeptical as a microbiologist of many of the responses to the pandemic. I think that what was done was disproportionate with regards to lockdown and masking. And I think that although I still believe the vaccines had some merit in the old and vulnerable, given us a couple of doses, I do think it was reckless to go about giving multiple doses to everybody, and it was reckless beyond belief to give these short efficacy vaccines to children who were at no risk whatsoever. So I was involved with Toby and the Daily Skeptic, and they one day they published an article that saying, and I forget who wrote it, it wasn't one of the in-house team, saying that Lucy Letby should hang. And I thought, this is, you can make a legitimate case for the restoration of the death penalty, but this was absolutely the worst case to make that argument based upon. I mean, she's convicted mostly by majority verdicts on circumstantial evidence, apropos with which there is substantial doubt coming from various quarters, people criticising the notes, people criticising the medical diagnoses, people criticising the statistics. So I wrote for Toby, trying to rebut this article saying that she deserved the death penalty. And then he invited me to come back and write a fuller review of the case, which I did. And on the strength of that, I was going to go on Piers Morgan's show on Talk TV, but that unfortunately was on the day when she was charged with the further case of, was it Baby K, or for a retrial for, was it Baby K? I forget which letter.
Yes.
And of course, reporting restrictions came down. I had a day's walking interrupted because I'd gone back to prepare for this interview, which didn't then take place. And Piers instead interviewed somebody who had won some chess game, and there were strange allegations that he was getting instructions via anal beads or something equally disgusting.
Yeah, there's going to be.
That was how I got involved. So I was commenting before the reporting restrictions came down, and then, needless to say, there was the further conviction, reporting restrictions were lifted, and then there's been a real slew of commentary, of analysis by yourself, people you've interviewed, and many, many others besides, again and again, criticising this case, whether from microbiological and clinical standpoints, whether from statistical, or saying that actually these rambling notes were written when Lucy Letby was under some form of psychotherapy, stress counselling, or whatever, and they weren't worth the paper they were written on.
Yeah.
So that's what brings me to the present position.
Yeah, absolutely. So to a very great extent, you've answered this already, but as we sit here today, what do you think is the most troubling or problematical aspect of this case, particularly in terms of scientific evidence?
Well, the whole damn lot of it. She has been blamed for half the deaths and a string of collapses that occurred in a unit which clearly had extreme problems and was not providing good care, and which, frankly, my expertise was a microbiological death trap.
Yeah,
So it's, you wouldn't hang a cat on this evidence. And
yes,
yet she has been imprisoned for the totality of her natural life.
yeah, absolutely. So we're going to go on later to discuss the death trap that you just described. Um, but we're going to go over some other questions first.
Cool.
Um, the first one is I had pretty much exactly the same journey as you because I became interested in this almost exactly the same time. I saw the confession note. I thought, come on, this is never a confession note. And so probably our understanding of it evolved similarly, I would say. And then I sat down in February, was it of this year? It feels like it was years ago, but was it of this year, the panel?
Yes, it was. Shuli's
Yeah,
panel was this year.
that feels like 6 years ago now, but yeah, it was just earlier this year in February.
Mhm.
So I sat down and watched that, and you will have done so as well. So
Indeed.
how did you feel when you saw that press conference, and how would you reflect on it?
It was extremely impressive, and it was a devastating analysis. What it brings out to me, and remember, I'm a scientist. I've worked in medical microbiology, but I'm a PhD. I'm not a medic. What it brought out to me in such detail was the deficiencies of medical care, basic things that they'd got wrong. The diameter of a breathing tube so that it didn't function, it couldn't pump oxygen rather, into the lungs adequately. Management of intravenous lines in baby A, where the line blocks and then they or rather it's not getting into the vein, they struggle with it, they finally get it into the vein, and potentially it's formed a clot at the end, which they dislodge with the thrombus, then killing the baby. The case of baby O, the poor infant who had the bleeding within the liver hematoma, where they'd overventilated the baby, they'd pushed the abdominal organs down. They had, in all likelihood, a slow bleed within the liver that turned into a big bleed. And one of the physicians, thinking that the distended abdomen, no doubt from the excessive ventilation, was due to an accumulation of gas, tries to relieve this accumulation of gas by inserting a needle at the wrong side without any imaging guidance, and draws back blood. Strong probability hit the liver, and which had this internal bleed already. Hemoglobin drops catastrophically. I mean, as I listened to Shuli's teleconference there, it's just a catalogue of poor management. The mother of baby PhD, her waters broke considerable time before she delivered the baby. And that exposes the baby to infection from her vaginal flora. She should have had antibiotics to make the delivery safe. She didn't get them. This is a catalogue of bad care.
And some of these things are quite basic. Would you not agree?
I'm not a physician, but they strike me as fairly obvious. They clearly struck Professor Lee and his panel, who are experts, physicians, as basic. He makes the point that some of the errors were things they teach their junior trainees never to do. He makes the point that at least one of the consultants, quote, "This is a doctor who did not know what he was doing." I've not heard any of those people come back and rebut. And some of them are identifiable. I have not heard any of them come back and rebut what has been said about their failings.
No, I don't think that's happened. So, yeah, overall, it painted a very dark picture, you might describe, of that ward, really. So we're going to talk about your area of expertise now, which is the biological field. So I want to, you've already given a bit of your opinion on the presence of pseudomonas on this neonatal ward and the significance of this, but could you firstly tell us about the bacteria itself?
Sure, I've had a relationship with Pseudomonas since starting to do a PhD on antibiotic resistance in Pseudomonas, 45 years ago now. So I've a good deal of my life has involved Pseudomonas. It's a bug which naturally lives in water. It does, historically, it did nobody any great harm whatsoever. As late as the First World War, physicians were quite happy if a wound got Pseudomonas, because if Pseudomonas got in the wound, then the bacteria that killed a wounded squaddy quickly, streptococci, wouldn't get in. But we now live in a world where medicine has gone on and we have sick and vulnerable individuals who are prone to be colonized and infected by Pseudomonas. And it's a resilient sort of bug used to living in natural environments. It can get into virtually any body site, and in the vulnerable, and that includes very small infants, it can cause severe infection. And because it's antibiotic resistant, it can be difficult to treat. Now, its other trick as a bug that lives in water is that it likes human-built water systems. So it gets into a hospital tap, it can grow back up the pipes. And it is extremely difficult to get rid of it once it's done that, because it forms what's called a biofilm, which is a sort of structured community of bacteria growing back up the pipe. And if you search the literature, you will find descriptions of what happened at St George's Hospital in London, where they had a major problem with Pseudomonas in the pipework, which then this same strain of Pseudomonas, which was particularly antibiotic resistant, popped up all over the hospital. And that was because it was in the water system. Ultimately, they did a lot to the water system. They got rid of the problem, and they did their utmost to manage it. But it does show what a problem this bug can be. And to illustrate what it can do to small infants, the best example would be Belfast, where one of the maternity hospitals there, must be about 10, 12 years ago, they had the death of 3 infants who had been washed with tap water. And they're obviously very vulnerable infants. These were not normal, healthy babies, but we're talking the same sort of category that Chester had. And the water was contaminated with Pseudomonas. And a lot of thought after that went into surveillance for Pseudomonas and ways to try to manage pseudomonas problems where they arose. And you see some of that reflected in Chester. They had identified that at least one, and as I've subsequently heard, two taps within this neonatal unit were colonised with pseudomonas. On at least one, and probably both of the taps, they had filtration systems that were supposed to take out the pseudomonas. But to quote Sarah Knapton's article from the Telegraph, the filters kept falling off. So you have there very vulnerable infants in a not well managed unit, which has a water supply which is contaminated. They know there's contamination of the taps, but they're struggling to eradicate the bacteria from this system. So that's one of their microbiological hazards. I've not seen anything to say that Pseudomonas was actually isolated from any of these babies, but it can be extremely difficult to get a good sample of blood or sputum or whatever from a very small infant. The microbiology can be difficult. So Pseudomonas is in there as a plausible cause of infection because we know it was contaminating the water system, and we know that contaminated water systems, or Pseudomonas contaminated water systems, are a hazard for such tiny infants.
Yeah. So regarding the testing for this, how does that work exactly? Because there's
Well, you must get a blood sample from the infant, or a sputum sample, or possibly a urine sample. That then goes from the unit to the hospital's microbiology laboratory. They then try to grow bacteria from that sample to identify it. That first step takes about 24 hours. And then using the bacteria you've grown, you do tests to see which antibiotics do and don't kill the bacteria. So that's another 24 hours. So there's a period, even if everything goes well, there is a period of at least 48 hours in which the physician has to treat the patient blind. They recognize that their patient has signs and symptoms of infection. They believe they've got an infection. They're waiting for a lab result. They must just give the patient an antibiotic which they think is likely to be active against the likely types of pathogen that patient would have. And that is always tricky, and it gets trickier as bacteria become more resistant. There's also the problem, a string of problems, that laboratories are less than perfect. Sometimes they fail to grow the bacteria. Sometimes because the patient is already full of antibiotics, it's impossible to grow the bacteria because the sample kills the bacteria. Sometimes the sample that is sent is poor quality. It's a small volume. It's just not a good sample. The classic would be pneumonia. You really want a sample from the deep lung because that's where the infection is. But the sample you so often get is sputum, which is full of bacteria from the back of the mouth, which aren't what's causing the problem down there. So there are lots of things that can go wrong with the process. I mean, the final part of my career, which I didn't address so much, working for University of East Anglia, was very much trying to find faster ways to diagnose what bacteria were causing infection. Because, you know, you and your listeners must perceive the problem from what I've just said, that for 48 hours, the patient's being treated blind. And some of the time, you get it wrong. You give an antibiotic that turns out not to be active against the bacteria that are present. And some of the time, you give an antibiotic which is using a sledgehammer to crack a nut. You've given some super powerful antibiotic, and the patient's got some wonderfully susceptible bacteria and you've destroyed your patient's gut flora and done all sorts of undesirable things to them. So there's a balancing act here, and many of us believe, though God knows it's slow progress to get there, many of us believe that the answer to this conundrum lies in faster and better diagnostics. And, you know,
Yeah. So
we know already that if you use PCR, you will find a polymerase chain reaction on respiratory secretions. You will find a pathogen in 50% more patients than if you're following the classical culture methodology.
right. So based on what you said, I'm very doubtful that they've tested for this because, firstly, we know it's an incompetent unit anyway.
Mm, mm, mm,
Secondly, we're going to discuss more testing stuff later in this interview, but there's a constant pattern of them failing to do testing. For example, they didn't do the insulin test correctly, but
mm, mm,
several others as well. And then the third thing is it wasn't cited in court, as far as I'm aware. I mean, I've looked as much as I possibly can, and I've never seen, right, we definitively did this test, and it there's always these. There's always often in the court cases these references. Oh,
mm,
this testing should be done, and then it just
mm.
disappears. It just
Yeah.
disappears out the discussion.
What I would observe there is that there are indictments, I think, for 17 babies. And the analysis that I've seen suggests sepsis. Let me look at my numbers, which I scribbled down here. Infection is noted by Shuli's panel in at least 6 out of the 17, sepsis in 6 out of the 17, not perfectly overlapping with the 6 where it says infection, and at least 10 of them, and I think there's at least 3 more, were receiving antibiotics. So somebody somewhere at the time thought they had infection. So infection numerically is right up there among the problems. Whether there are outbreaks involving one strain of pseudomonas, or whether it's all different things, or whether it's E. coli coming from the sewage leaks, that we cannot say. But there has, as you allude to, there has been a dearth of microbiology infection. The only bug that I've seen named, I'm sure we'll come to it, is the stenotrophomonas maltophilia from, I think it's patient I. But except for that, I have seen no name of a bacterium from any of these patients, despite the fact that definitely 10 of them, and I suspect at least 13, were on antibiotics, which implies that somebody somewhere thought infection was likely.
Yeah. And we're going to discuss sepsis now, but before I do that, I'll just mention to you that the third insulin case, which is child Y, is described as that's got sepsis all over the notes as the third.
Yeah, well, that one wasn't on the indictment, but it's
Yeah.
getting, and it's one of the insulin cases. Definitely, it's L. I think it is was on antibiotics, and so that implies somebody thought there was infection there. And as I read sorry, F definitely was, not L, but L also possibly was. One of Sarah Knapton's articles, I believe, indicated both insulin babies were on antibiotics, but F definitely was.
Yeah. And then I should mention as well that the non-indictment infants all had signs of infection as well.
Mhm,
Sometimes that was cited as the cause of death, but they just weren't in the indictment, of course. So,
mhm.
but we'll talk now about sepsis. So could you discuss the relationship between Pseudomonas and sepsis?
Well, Pseudomonas is, I mean, sepsis by definition is the combination of the infection and the body's response to infection, the fever, the sweats, the series of biomarkers, C-reactive protein, etc., that go up the migration of white blood cells and the cytokine response. Sepsis is the syndrome. Infection is the cause of the syndrome, and Pseudomonas is one of many bacteria that can cause sepsis in the vulnerable, which, the very old, somebody who's got a cancer, somebody who's had major surgery, or as here, very small, premature, vulnerable infants are at risk from pseudomonas. Somebody in good health is not at much risk from pseudomonas. I mean, look, in my early days of doing laboratory experiments somewhat dangerously, once got a tremendous mouthful of pseudomonas aeruginosa from a result of mouth pipetting it, which was still acceptable in those days, but would now be very deeply frowned on, and rightly so from a health and safety perspective. And I lived to tell the tale. I drank some very strong coffee afterwards, was get rid of the taste. That was perfectly all right. But you know, I was in my 20s then and in the best of possible health.
Mm.
Somebody who's old and vulnerable being exposed to a lot of pseudomonas is at risk, or as here, a small infant. And sepsis can ensue, and it's because it's so antibiotic resistant, there is a bigger likelihood that whatever first line best guess antibiotics are given fail to cover it.
Yeah. So we obviously know that sepsis is a major threat for young
Mm.
infants. So that was the fact that it's essentially endemic on this unit. So
It's certainly in the water. I wouldn't go so far as to say it's endemic. They
okay,
weren't big. It may have been. We don't know. I mean,
yeah.
as you know, where are the microbiology reports for the unit from this period? What else had the infection control team found in addition to noting these pseudomonas colonized taps? Infection was such an obvious cause of a spike in deaths. What investigation did they do? I've yet to see any clarity on this. Or weren't they called in at all?
Well, we don't think they were because we haven't seen any. They
Well,
didn't.
they must have been to some extent. They must have done something because they found the Pseudomonas
Yeah.
colonized taps. But
Yeah. Well, we're going to go on. We'll discuss this now. So I was going
mm,
to show you a document, but I haven't prepared this. So I'll explain this to the viewers.
mm,
I know that you've seen this document because I've shown you it previously. So we're during the Care Quality Commission review. I've put this document in a previous video. It's
mm,
a kind of information gathering pro forma, you might describe it as. And in the box at the bottom, they've made a load of comments about sepsis and pseudomonas. And then when they filed their final report, the Care Quality Commission, there's just no mention of this whatsoever. So when we spoke via email on this, you had quite a strong view on
mm.
what should have happened and what had happened. So
Yeah,
I'd love to hear that now.
yeah. I mean, just remind me and your viewers of the date of this
I
document.
believe this was February, wasn't it? February 2016.
So right in the middle of this series of deaths at the unit. And here they've got microbiological contamination with the Pseudomonas. They've got a spike in deaths. You just have the sense that the Care Quality Commission have gone through a tick box exercise. They're aware of the deaths, they're aware of the Pseudomonas, but they just sign off as if everything's okay with this unit, when clearly everything was not okay with this unit. It was badly run. And what's even worse is the sewage leaks do not even seem to be mentioned. And it's come out subsequently that one of the unit's ways of dealing with sewage leaks from the ward above, or the plumbing of the ward above, was to stick bloody nappy pads over them. Again, from Sarah Napton's excellent research for the Telegraph. I mean, how can such a shithole of a unit get passed by the Care Quality Commission? Even Dewi Evans, give him his due, interviewed by John Swinney, I think it was, on one of his podcasts, said, you know, when the sewage leaks were raised with him, so it was appalling. He would not have allowed that in Swansea in his time. What were the consultants, what were the management doing about this? And here's the Care Quality Commission coming round to have a look, noting some of the problems, but not being apprised of or noting other problems and signing it off. This is appalling. I mean, why do taxpayers pay for this? You know, they should be doing their job properly.
Yeah. I think what is important to emphasize is that they knew. You know, they could, as a defense, they could say, "Oh, we didn't know anything about it. We weren't informed of this. We didn't spot it." I suppose, but they knew because it's in this.
But they certainly knew about the deaths. They certainly knew about the pseudomonas. And they seem to just shrug it off.
Yeah, I mean, it's just not
It,
in the report, and
it's
it's not in,
appalling.
it's
It's,
not in the
it, it,
statement to Thirlwell either.
it's appalling that a supervisory inspectorate body has failed utterly to do its job.
And there's no defense for that, is there really?
None whatsoever.
Okay, so
Certainly since they know about the pseudomonas, they know about the deaths. It's possible they were not aware of the sewage. But again, somebody at the unit has failed to do their job, saying, look, we have a problem here. And, this was the unit's opportunity as well to say, we have a problem and our blasted facilities management do nothing about this. Certainly, if I had been in charge of any sort of unit where there was such a problem, I'd been playing hell at the management saying, look, we have the CQC coming round such and such a time. You need to get this permanently fixed beforehand. Otherwise, I am going to raise it with them and say that you are failing to sort out my problem, good folks from facilities management. And
yes.
if they fail to do anything about it, I really would tell the CQC about it.
So we know the CQC knew about this. We know the hospital knew about this. So do you think it's reasonable to say that, the pediatric leads, the consultants on this unit should have taken direct action?
Yes, of course they should. They are primarily responsible for running the unit, and they have been running something which was microbiologically unsafe, both in terms of the colonization of the water supply by pseudomonas, but even more obviously with regard to the plumbing leaks, which would be a source of fecal bacteria, particularly Escherichia coli, as we commonly call it E. coli, which is always present in feces. It's always going to be present in sewage, and which can again cause opportunist infections, virtually any body site, including causing sepsis and bloodstream infection in vulnerable infants. So, there are two named bacteria, Pseudomonas aeruginosa and Escherichia coli, which are both obvious microbiological hazards within this place. And the consultants presided over this unit and appear not to have raised the issue at all. I mean, there should be a log of their complaints to facilities management. Again, I won't say much in favour of Dewi Evans, but at least he says when he's interviewed by John Swinney that as if he was not aware of the sewage problems, but if he had been, and if it had been at Swansea, he'd have played holy hell about it. And I tend to believe him.
Yeah, I'm sure that's true. I find it hard to believe he wasn't aware of the sewage problems because it was in the
Yes, yeah,
but yeah, obviously clear. I mean, to be fair, you'd shut down a factory, or wouldn't you? Or definitely a residential building if it had sewage in it,
Absolutely,
let alone a hospital.
absolutely.
It's just indefensible. And how serious would sewage be on a neonatal unit?
Well, as I say, it's full of bacteria. I mean, the majority, the weight of sewage is bacteria. Many of those bacteria will die once they're exposed to oxygen, but Escherichia coli, E. coli, will certainly survive for many hours. And again is an opportunistic pathogen. It's actually the commonest cause of bloodstream infections in the UK these days. Now, most of those are in adults, and most of them are ascending infections from the urinary tract. But it's a very common cause of blood poisoning and sepsis, and very, very plausible as a pathogen here in the Chester unit.
Hmm.
So certainly as plausible as Pseudomonas aeruginosa. And in terms of the signs and symptoms of infection, they can be very vague in preterm infants in particular, and you wouldn't know from the signs and symptoms whether it was a Pseudomonas or an E. coli or any of a dozen other bugs. It's only once, if the laboratory has got a culture and tested, that you know what the pathogen is.
Hmm. So you mentioned this nappies on the
Mm,
ceiling scenario. Could I ask you about the recent article that you wrote about this?
mm.
Could you just expand on that and say,
Yeah, I mean, it comes from investigative journalism again by Sarah Napton on the Daily Telegraph, reporting that, as was well known, one of their problems was sewage leaks from the ward above. Right? This came out in the original trial. Um, But what then came out from Sarah Napton's research was that one of their ways of dealing with these leaks was to put absorbent nappy pads over them,
Hmm.
which I suppose would stop any drips, but you end up with a nappy pad which is absolutely laden with bacteria.
Hmm.
This is just an appalling way of dealing with plumbing problems. We come back to the same point. The people in charge of this unit should have been playing holy hell at facilities management. And if facilities management would do nothing about it at the trust board, and if they would do nothing about it, then at the CQC.
Yeah, absolutely. So I've got a couple of questions for you now that we've touched upon already, and I think you can
Mm,
probably give pretty short answers to these questions.
mm,
So Professor Shuley indicated that this neonatal unit should have been closed down. Do you agree with this verdict?
yes.
I don't think we need to expand on that at all.
There's no need. I mean, clearly it was providing substandard medical care, and it was microbiologically unsafe. You add those two factors together, it's hard to see why it should have been allowed to continue.
Hmm. And so also,
Or at the very least, it needed a very rapid and substantial reorganisation, which it got. I mean, it was reduced from a level 2 to a level 1. So while it wasn't actually closed, even the management recognised it had to be downgraded. But I would sincerely hope that the plumbing was also sorted out at the same time.
yeah, absolutely. Um, so we'll move on to talk about stenotrophomonas
Mm,
multifolium. So this is mentioned as being detected in surveillance cultures from the endotracheal tube of child eye.
mm.
Could you firstly just tell us a little bit about this bacterium?
Yeah, it's like Pseudomonas aeruginosa in that it's an environmental organism. Grows on plant leaves. Again, it can get into water systems. It's not as bad as Pseudomonas aeruginosa there, but it likes moisture. It's very, very versatile in what it can live on and therefore where it can grow. And the first time I encountered it was in my honours project at university, looking at the types of bacteria that grew on leaves of plants from a very remote area on the island of Mull, and there was stenotrophomonas maltophilia in the leaf flora. Um, Again, in the very vulnerable, it can cause infection. Um, it's not as bad as pseudomonas aeruginosa in general. It's less able to attack tissues, but it can cause infection. What is notable is that it is extraordinarily resistant to antibiotics. And the antibiotics that you need to use, certainly 10 years ago, against stenotrophomonas, are not the antibiotics that you would normally be using in an infection in a small infant. In particular, you would normally, if you knew it was a stenotrophomonas infection, you would use a drug combination called cotrimoxazole, sulfonamide, together with trimethoprim, which is not the sort of drug you'd normally be using for infection in neonates. So if this bug was causing an infection, and that's not clear, it was from the endotracheal tube. It may simply have been colonizing, or it may have turned invasive. I don't think anybody knows definitively. But if it had turned invasive, that kid should have got an antibiotic, which frankly it was very unlikely to have got.
Yeah. Now, there's some supposed controversy over this, which I personally consider to be total nonsense. We have Thirlwell lawyers trying to claim that stenotrophomonas multifili had been ruled out by testing. But when I researched this, the testing required to do this is very specific, and there's no evidence of this ever conducted. Obviously, we've discussed testing on the unit. I think we can rule it out
Well,
entirely. But
I simply don't understand the statement,
mm,
because it is the one bacterium that is actually named.
mm,
Some testing was done which identified that stenotrophomonas multifilia was there.
right.
Whereas we have lots of other infants on antibiotics and or with diagnosed infection and sepsis from whom we don't have a bug. So this is the one patient from whom we do have a bug, who was very definitely on antibiotics, who was reported at least at one stage to be septic. Whether they were septic owing to stenotrophomonas multifilia or whether to something else, fair enough. I don't think we definitively know that. But where is there evidence it was merely a colonist rather than a pathogen?
Mm. Can
The other thing to say about stenotrophomonas is this: that is often, because it's so antibiotic resistant, it's often the last successor organism. You have a patient with one infection, you kill that, you've left tissue on which the normal flora has been disrupted, so something else gets in, then something else. And because stenotrophomonas is so naturally resistant, it's apt to become one of the last bugs present. If you go to hospitals, say in Southeast Asia, where many of us here would think they overtreat patients, that they put on antibiotics for too little reason and frequently for too long, then you see a lot more steno than you will here. Precisely because it's this last, and this kid, this poor infant, I think the episode of sepsis was very early in his or her life, and he or she ultimately succumbed at about 2.5 months, with the steno found relatively late in that period. How much of that child's life had they been on antibiotics? How much selection pressure had gone on for, final successor bug? I've not seen those details, but I have certainly seen nothing that rules out steno as a cause of infection and purely a colonist. It may be,
Well,
but
I think that the lawyers are just effectively citing Dr. Evans, who makes these claims. Oh, infection doesn't matter in any of these cases at all. It had no impact. But then again, he ruled out everything other than Lucy Letby. He ruled out poor care, he ruled out mistakes on the unit, he ruled out infection, he just ruled out everything other than Lucy Letby. Yeah.
even in cases like baby D, where infection indubitably was part of the story.
Yeah, I mean, in with child C as well, there's a very clear bowel obstruction that somehow has been discounted. I can't understand how. All the signs are there of a bowel obstruction, and when you speak to neonatologists, they just say it's quite a straightforward, obvious case of bowel obstruction. But this is
And
ruled out.
ditto Child O, where he is so convinced that it was assault by Lucy Letby that caused bleeding in the liver, when there is no doubt that the child had already got this subcapsular hematoma, where there was very vigorous resuscitation attempts, where there was no doubt that a needle was inserted and may very well have hit the liver and caused bleeding. Indeed, the fact there was such a sudden drop in the hemoglobin level rather suggests that is what went on.
Yeah, absolutely.
He has latched on to very fixed ideas, and because he is so fixed, and in a way so clear on what he's fixed on, is actually very good in front of a jury.
Hmm.
And that surely is the failing of the original defence to bring solid counter evidence.
Yeah, I think it was. I think also the judge didn't help by making the process as difficult as possible for the defense.
True.
I believe strategically they wanted to do something different from what they
Yeah,
had.
yes. As I understood it, Ben Myers wanted to handle case by case. So be prosecution evidence, defense, expert evidence for child A, B, C, D, and so on and so forth, as against the judge insisting that it was the whole darned lot, followed by for the prosecution, followed by the whole lot for the defense. You've presumably also seen what Philip Hammond wrote in Private Eye last week, to the effect that there was a pre-trial meeting between the defence and prosecution experts, with the defence heavily outnumbered and rather accepting the evidence in the case of the insulin babies that they had exogenous insulin. And did this make, as Hammond suggested, this make the defence very nervous about putting up their own experts when they were accepting, very probably wrongly, that exogenous insulin had been given? Does this explain why the defence didn't put up? I think it was Michael Hall of Southampton who had been briefed and had been preparing expert reports on the infants.
Yeah, I think it must have been a factor. Obviously, the big problem with this case is that Dr. Evans is willing to say absolutely anything, seemingly, as long as he's in the court case. That's all he seems to be bothered about.
Yeah, I mean, without knowing the man, it's hard to be definitive. But what strikes me is that he takes an extraordinarily partisan view. He is there as the partisan of the prosecution here, perhaps the defence in other cases where he's occasionally worked for the defence, and he speaks of, I have been involved in however many cases, let's say X cases, and I have won X minus one case.
Mm.
That, to my mind, is not the role of an expert. An expert is to try to weigh evidence as impartially as possible, and not not to be thinking of, well, I've been retained by this side and I've won for them in such and such a proportion. Maybe that's appropriate in commercial law. I don't think it's appropriate in the criminal law at all.
No, I think we would all agree with
You
that.
must be more dispassionate and seek to be absolutely objective when somebody may lose their liberty for effectively the natural duration of their lifetime,
Absolutely.
which is a shocking sentence on anybody.
Yeah, yeah, absolutely. So to give one example, Professor Sally Kinsey is asked about air embolism.
Mm,
She sort of semi-endorses the theory of Dr. Evans. And then, but when the cross-examination, she says, well, actually, I don't know very much about it. And then she's asked about the literature, and she says, yeah, it's pretty weak, to be fair. Um, but when Dr. Evans is asked about it, he tries to defend the
mm,
literature, and he
mm,
tries to defend, but he can't because it is, he's used like something about deep sea diving, and there's a paper in there about animals. None of these papers are diagnostic apart from the Shuley. Shuley's the only, and Tanswell is the only diagnostic paper. All of the other papers are used to give case studies. So he always says this, oh, I used 18 papers, but there's no diagnostic papers there.
Well, he asserts that Lucy Letby killed, what is it, five of these babies by embolism. It's around about five. Um, Nobody observed her doing this. No, and it would not be easy to do. These are tiny mites to find unwatched a vein, get air into it. You know, it's
A lot
not
of,
again, it's not like an adult who's got large veins on the back of the hand which you can get a needle into, or
yeah.
it would be tricky to do, and it would be extremely tricky to do it repeatedly in a unit where somebody's like to find you doing it. It would be a very, very difficult crime to commit, irrespective of the total lack of direct evidence. And it's curious that both Dewi Evans and Ravi Jairam both latch onto the Shuley paper, and in fact misrepresent that paper, as Shuley himself says, that the rashes that he described were in relation to air in arteries, not air introduced by the venous system. That
Pretty fundamental error, you'd have to
you know,
say. Um,
well, I mean, look, if I thought I had the interpretation, if I'd seen some unusual phenomena, strange migrating rash or whatever, and I dug about and dug about trying to explain and understand what had gone on. And I found somebody had written something 30 years before that I thought was relevant, and I couldn't find any subsequent corroborative paper. I would make an effort to get in touch with the person who'd written that thing 30 years ago and say to them, look, I've not seen anything to confirm this. Do you think it still holds good? I would not hang my case on something that's 30 years old without subsequent corroboration. I would view it as a reckless thing to do in scientific investigation, let alone in a criminal case where somebody's liberty depends upon it.
Absolutely. So we're going to talk now about child G.
Mm-hmm.
So this is a particularly premature and vulnerable infant in which the panel cited enterovirus as being significant
Mm-hmm. Yeah.
collapse. So could you explain how they would test for enterovirus and whether also this is something that the hospital should have missed?
I mean, normally now viruses, you can't grow viruses. You could in tissue culture, but that would be an incredibly tricky way to do it. So the normal way that you would diagnose a virus now is by polymerase chain reaction, essentially what was done in all those testing centres during COVID. This is a common virus. It can cause respiratory symptoms. Sometimes in very small infants, it can cause cardiac symptoms as well and be quite serious.
Yeah. So do you think they should have detected this?
I do not know what virology was being done at the Chester laboratory. They certainly should have suspected it based on the clinical symptomology. Watery stools, respiratory symptoms would be a pointer. But
Yeah, absolutely. So I'm going to talk now about a few of the criticisms made of the Council of Chester by the international panel of
mm,
experts. The first comment is that the hospital disregarded surveillance warnings about infectious bacterial colonization. Could you explain the seriousness of this and also whether you see evidence for poor practice on the unit?
well, there's two things which we've really quite covered quite extensively already. One is Pseudomonas aeruginosa, and I take that to be what they mean by the surveillance cultures, that the surveillance cultures, the sampling of the tap water, had found this Pseudomonas. They had been unable to eradicate the Pseudomonas from the water supply. There's then on top of that the sewage leaks.
Yeah,
So you don't need a surveillance culture to see that you've got a problem with a sewage leak. You've got a sewage leak.
it's
It's the
pretty.
last thing you want around premature, vulnerable infants. Um, and you know from the fact it's a sewage leak, it's going to be absolutely full of bacteria, most relevantly Escherichia coli.
Yeah,
We don't need a culture to tell you that. It's a
no,
sewage leak.
no. So another criticism was poor environmental temperature control in the facility. So could you explain the significance of this from a microbiology perspective?
Yeah, I saw that, and I would need that elaborating
Okay.
to me because these infants would be in incubators, which should have had better, or should have had at least internally, they should have had good temperature control. So I'm not quite sure I follow what they're getting at there. Perhaps I'm missing something, but I'm certainly not sufficiently certain to be able to comment further on that
Okay,
one.
no problem. And again, this might be something you don't know too much about, but we can talk about it hypothetically. Uh,
Mm.
A third criticism was the lack of appropriate facilities for sterile preparation, e.g., IV drugs were prepared in corridors. So let's just assume, for the sake of argument, that's correct. I don't think we know the full details.
Mhm.
Um, could you explain the significance of this?
Well, it increases the hazard that contamination gets into a line, which is then going to be put into a patient's vein. You would have to know the detail of how much is being prepared on the ward and how much is coming up from the hospital pharmacy. We'll want to see the direct ways of working, but you're putting something into somebody's vein. You really want to be absolutely sure that you've got a sterile assembly there.
Mm, absolutely. And of course, like putting something into a vein is always, it's the most direct way, isn't it? There's something
Mhm.
going to your system, essentially.
It is the best controlled way of delivering an antibiotic because you quickly get it into the central bloodstream and to sites of infection. And you've got optimal control of the amount of antibiotic. Whereas if you're given a tablet of antibiotic, if you've some gut problem, well, maybe you don't absorb as much as a normal person would, etc., etc. Whereas if the antibody is put directly into the bloodstream, you've got good control of the dosage, and you're sure it's all gone into the patient.
Yeah. Okay, that's great. I want to briefly discuss the insulin testing because
Mm,
I think we both believe that there were some mistakes at the laboratory here.
yeah. Now, I'm no endocrinologist, so I will
I understand.
not comment on insulin testing directly, but what I'm happy to comment on is laboratory management and assurance of quality by laboratories.
Okay.
My experience of that is, as I said at the start of this interview, through managing microbiology laboratories, but there are certain general rules on quality control which apply to any service laboratory, be it microbiology or blood chemistry, as here.
Okay. So with that in mind, there's this issue where there's a lady working at the laboratory who gathers certain results from the
Mm,
cancer test from these suspected insulin infants that ultimately Lucy Letby ended up being convicted on. And she makes this comment about the cases should now be sent to Guildford for exogenous insulin. And this never happens.
mm.
So do you have any comment about that, or what
Well,
observation?
what I understand was going on was that the samples, I'll come back to you, lady, in a moment. The samples were sent in the first instance to a laboratory in Liverpool to measure the insulin levels. And the laboratory used an immune assay, which is adequate for routine testing, but is generally accepted not to be suitable for forensic testing, which you would ordinarily demand, surely, for any legal case.
Yeah.
Moreover, and this comes out very clearly in the reports from Shu Lee's panel, there is debate about whether expected insulin to C-peptide ratios in neonates bear any relation whatsoever to those that you would expect in older children and in adults. So something which appears bizarrely, which would be exceptional and bizarre and suspicious for an adult, may not be unusual in a small premature infant. And the next thing is that the test that was being used, which was a Roche assay, Roche being the manufacturer, immune assay, isn't licensed for use on samples for children, probably for the reason I've just said, because there's debate about what the level should be in children, in small or children, for neonates, I should say, in the first place. And then there's the point that this Liverpool laboratory failed a quality assurance test shortly after the results on babies L and F, who are the two insulin cases. So we've got four things there. An assay which is not forensic standard, debate about what the insulin to C-peptide ratio should be in a premature infant, an assay which is not licensed for neonates, and you add all that together, it's clearly unsatisfactory.
Hmm, absolutely. So when
You know, when I ran laboratories, we would each week we had so many bacteria sent to us from hospitals up and down the country. We'd run our tests on them. We would then have a review meeting before the results went out. And we'd go through them. All right, this bug, all the results make sense. Likely mechanism, such and such report goes out. Bang, 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 bang. And then you'd come to one that was grossly anomalous. So this pattern of results does not make sense for this species of bacteria. What's wrong? Have we tested a mixed culture? Have we got the identification of the bacteria wrong? And that's all too often that was the problem in our case, that, we'd been sent to buggers one species, we got a set of antibiotic results that made no sense for that species, and actually it was another species. So in the end, we took to checking the identification for every bug that was sent to us. But this is straightforward pre-reporting quality control. Was the Liverpool lab doing anything along those lines? As I say, it was my fourth point, that the lab failed its quality control sometime later. I do not think that these results were sufficient to convict anybody, given that string of problems. And yet, tragically, they were the area that the defence failed to properly contest. And indeed, as I read Phil Hammond's article in Private Eye of last week, essentially it was accepted by the defence that the infants had, from these high insulin levels, the infants had been given exogenous insulin. Now, in defence of the Liverpool lab, which I've just criticised using inappropriate assay, failed quality control, etc., etc., I understand that their reports did say that if exogenous insulin is suspected, this test should be reconfirmed elsewhere by a laboratory using a different method, which I take to be the Guildford laboratory mentioned by your Mrs. Waite, was it?
Yeah,
in any case, all this comes back to the same point, that unsuitable test, lab that had failed its quality assurance, debate about what the levels should be anyway.
Yeah, absolutely. So in court, Dr. Anna Milan, and we're not here to slate Dr. Anna Milan, but she made some very strange comments, considering everything that we've just discussed and everything that you've just said regarding exogenous insulin, suggesting that tests were not sent to Guildford to establish whether or not exogenous insulin had been administered, when it is well documented and undeniable that this is just plain wrong. So, can you think of any good reason for this? Is there any justification for such a remark? Could she plausibly not be aware of this?
Well, she must speak for herself, and as I say, I'm not an endocrinologist, and I wouldn't want to talk about what insulin levels should be and should not be. But when the Liverpool laboratory themselves are saying that if there's a suspicion of exogenous insulin, then you should get this checked elsewhere by a different methodology, then why does she dispute that when it's asserted even by the source laboratory, which is using a test which is not of a forensic standard, which is not licensed for use on premature neonates, where there is debate about what the insulin level should be anyway. I cannot see what her logic is. You would really have to ask her to explain what her logic is, because I don't see it.
Yeah, I agree.
Possibly she has some very good logic, but one would want to know what it was.
Yes, absolutely. So finally, I would like to discuss with you Lucy's current situation.
Mm.
Obviously, we've had the panel come out with this new medical information, these new very detailed reports. That was in February. We're sitting here in September now. We've not heard anything yet. How do you feel about the current situation for Lucy and the kind of overarching situation, I guess?
Well, it's depressing, and it points to a serious problem. With, sorry about that.
No problem.
It points to, let, can we just pause for a moment?
Yeah,
Let me
yeah,
take
let's just
that.
pause for a sec. That's not a problem. Domestic things.
Hello?
Here you go.
Hung up on me
And
immediately.
you were recording. Yeah,
Okay, just ask me the question again and
yeah,
we'll.
so just let's can we reflect on Lucy's current situation,
Surely, of
the
course.
CCRC and so forth?
Well, it's clearly depressing because so much evidence has been pulled together which challenge these convictions. And yet the wheels of review grind so extremely slowly. And meantime, she's stuck in prison. She was what? She was mid-20s when all this began, and a time of first arrest. She's mid-30s now. What's she going to be? Is she going to be 40, 45 when this finally comes back to the Court of Appeal? It's an appalling situation for anybody to be in. Justice should be swift, and the rectification of any false conviction should also be swift. But I'm afraid the justice system in this country is failing on that account. That we saw Andrew Malkinson in prison for 17 years for a rape he did not commit. And the Criminal Cases Review Board took many years to reconsider his case, even though there was evidence to exonerate him provided years and years ago. We see the poor unfortunate postmasters and postmistresses a decade and a half on, still awaiting serious compensation and redress for a mass of wrongful convictions. We see the HIV infected blood scandal still being looked into 40 years after the event, as the people who were infected steadily die off. Uh, you know, and I think many others of my generation were brought up to be proud of British justice, but we see malfunctioning most terribly at present. And Lucy Letby's case is one of the worst manifestations of this. That there is, as we've discussed, and as many of the other people whom you've spoken with have discussed with you, there is very, very substantial evidence from multiple fronts to doubt the validity of a conviction. And yet, reviewing it, let alone reversing it, is so indescribably slow as a process.
Yeah. So I was actually asked in one of my question and answer sessions, how long do you think it would take you to come to a decision that this is an unsafe conviction? And I said I was pretty confident within a week, but I think within a month of research, it should be very clear that this is an unsafe conviction.
Yes, one can come to that view very quickly because so many people have looked at the basis of these convictions from different angles and again found them to be flawed. If you simply were given a case on which people hadn't done lots of other work and told, right, well, here are the court transcript, here are the original expert reports, etc., etc. It would take you a long, long time to go through everything and start to scratch your head and think there's something amiss here. But on Lucy Letby's case, so much has now been done by so many people from so many different angles that the unsafeness, the questionability of these convictions is really crystal clear.
Hmm. And I think you make a really important point, something important to clarify, is that sometimes if you get an appeal, it's on one technical aspect of the conviction
Mm,
or a very narrow aspect of it. This is coming from multiple angles.
mhm,
It's like a hydra. Like just, so many aspects of the conviction are unsafe. And you're not even really allowed to go into the fact that a lot of the procedure and a lot of the cross-examination and discussion in court is farcical. It's actually pain. I mean, I think people very kindly support me and listen to it, but I know people find it painful to listen to because it is just so bad and so unjust. And you're not even really allowed to put that in the appeal. You know, that's been in court, so now we have to put that on a pedestal. You have to find material ways that the conviction is unsafe based on fresh evidence. You're not allowed to say, "Well, look at the court case." Any idiot can see that it's unsafe.
mhm.
You're allowed to say that. So it's pretty staggering and pretty extraordinary, but we can only hope that it's dealt with as quickly as possible and that the appeal court deal with it as quickly as possible. I mean, it's going to be. I know that Colin Norris slash Colin Campbell had to wait, was it 4 years between the CCRC and the appeal courts, and he in total waited 14 years for his appeal to be rejected because the lawyers, in my view, took a terrible strategic approach. But still, he had to wait 4 years from the CCRC to the Court of Appeal. So we can only hope Lucy's case is dealt with more quickly than that. But we don't
Well,
know.
I mean, the thing the only thing that works to her advantage, surely, is the amount of public concern that this is regularly in the news, and all that news coverage is saying, "Oh, look, there is something or many things seriously amiss here, and it must be kept in the press. It must be kept on the agenda."
Yeah, absolutely. Well, that was obviously my purpose for writing the book. So
Surely.
hopefully that can play a role as well. Yeah, so that's all I've got to ask you today. So thank you very much for joining me. Thanks for giving your views. Thank you as well for speaking out on this topic and writing so well on it as well. I think we'll appreciative of that, and I think everyone listening to this is going to really enjoy the interview. So thanks again.
Not at all. One must do what one must, whether it's in respect of injustice like this or the many things that were done so wrongly and badly in the pandemic. I feel strongly on both, and
Yeah,
it is necessary to have the courage of your convictions in this life, or you do nothing.
absolutely. I agree entirely. So yeah, thanks again, and I'll speak to you again soon, no doubt.
Okay. Cheers then,
Bye
Chris.
now.
Bye.